practice putting on condoms and use these kinds of things.
So we'll split our.
Oh,
imagine a huge blackboard here, right? So this is. So okay, basically, people got to the point with safe-sex education where they realized we're giving people a lot of information. We teach them about abstinence, and then we find out that studies show that many people aren't abstinent. We teach them condom infos and information about other types of latex, and realize, hey, people still aren't doing that. Some are, but others aren't. And sort of the next step in safe-sex education looks at some of the reasons why people might choose to make decisions, say, not to use condoms. And one of the really useful tools around this is risk management. And what that does is it says, okay, people realize that their lives are risky. That in one of the analogies we like to use is to driving a car. And then if you look at something like driving a car, it's a risky thing to do. And that it's something that a lot of people do, but that if you go out, you could get killed in a car accident. You could have things go wrong on the highway. You get a flat tire and have to deal with that. There are bumps along the road, literally, in terms of what it's like to drive a car. And for many people, safe-sex education or sexual decision-making works the same way. And they recognize that there are risks involved in terms of what the risks of sex are for them. But they also realize that there are reasons why having sex are fun and pleasurable and are part of intimacy and are part of love and part of relationships for them. So a lot of the really interesting work that's being done in the field is around risk management, is to how people make decisions about risk in the context of their lives. So we'll talk more about that as we go along. Another that's very similar to risk management, but it sort of takes a slightly different approach, is harm reduction. Are people familiar with that term? Okay. Harm reduction is commonly used when working with injection drug users. In that, if you take an injection drug user who's at risk for HIV, as well as all the problems associated with drug addiction, and say, you need to be abstinent. Not just abstinent in terms of sex, but abstinent in terms of drugs. Cold turkey, don't do this stuff. People who work with injection drug users find that doesn't work. That the clients just aren't there and uncomfortable, and they lose people from their programs. So what harm reduction says is, okay, let's recognize that addiction is a really complicated process. And there are many steps to overcoming addiction. But that HIV is a serious risk for addicts who are sharing needles. So a harm reduction approach says, okay, let's recognize people injecting drugs, but teach them how to clean their needles. Or let's recognize that people injecting drugs and set up needle exchange programs. This isn't only true for injection drug users. This kind of approach can be used for, say, homeless and runaway youth, who their main concern that they're looking at, their main issue of the day, is not whether or not they're going to get infected with HIV, but whether or not they're going to have a place to stay that night, get enough food, the sort of basic survival things. The difference between harm reduction and risk management is sort of blurry, because both of these are useful tools. Risk management takes the idea that people are empowered. People are empowered to make decisions around safe sex. And what's helpful that you can do as RAs and as counselors and as faculty and as educators is to help people sort of work through that process about how to make decisions around risk.
And as part of all of those things, and then if you fit in, it's really important to us in our work, is the idea of the concept of being sex positive. That we live in a sex-negative culture, a culture that says that we can joke about sex, and we can snicker about sex, and we can have it all over our magazines and all over the television, but we shouldn't really talk about it honestly. And in the end, most people are still pretty embarrassed to talk about it and pretty ashamed of a lot of sexual thoughts they have, or sexual desires they have, or sexual things that they do. And coming from that sex-negative space and culture, if you can create a more sex-positive culture where it's more okay to talk honestly and openly about sex, we think that's really important as part of all of this stuff. To have, when you're teaching about condom use, to have that be really fun and safe space. So that we really see that the work we do, like giving workshops on how to get the sex you want, is an important part of safe sex education, because we know from many studies that when people feel like they can talk more honestly and feel better about themselves and the sex that they have and the sex that they want, they tend to be safer, they tend to communicate better, they tend to make better decisions about risk.
And also, it's one of the sort of fields to be able to follow how this trend works is around HIV test counseling. And then one of the approaches that people used to use with HIV test counseling is someone would come in, and first it's sort of like, the very sort of, the early 80s approach is like, what's your risk category? And if you were gay or bisexual man, that was bad. It was like, oh, you shouldn't do that, you can get infected with HIV. And the same with injection drug users or people who had a lot of sex. And then as we moved on, it moved to sort of like, the person came in and you were like, okay, here's a condom. You know, what you should do is use condoms. Which is fine, that worked for some people. But now, risk management takes more of a client-centered model. You're talking to people, people come in, and I use test counseling because often, I don't know if people are working sort of one-on-one, if people come in and they have concerns about.
So this would be a student-centered model.
Yeah, student-centered model is a good example of it. But assessing from people where they're at with things, where they're at in terms of what their own concern is about their risk. And realizing that for some people, condoms aren't it. You know, it might be other ways of reducing their risk. So let's pause for a moment and talk sort of what are your thoughts on all of this and your experiences working with these things?
I don't know, since I've been talking about this and talking about the difference between condom and then the other part, inclusive latex, I feel like I actually have questions, and it might be questions for students that at some point I'd like to ask that I didn't think about before. And that is, you know, we talk about condoms a lot, it's very well known. And even good workshops that do the inclusive latex stuff usually doesn't get beyond the 5 or 10 people who are in those workshops. I don't really hear that being talked about. So, I mean, I wonder, because, and I know we're not really going in that direction, but just to throw out there, a question I have are, do students know much about this beyond the ones who go out to educate themselves or who go to HIV testing to talk to somebody? And what I'm really interested in is sometimes, like, dental dams are directed more at the gay and or the lesbian community, and I'm wondering if heterosexual men ever consider this as a need, and I always feel like it's usually targeted at lesbians or bisexual women. So, I mean, that was just a question I had that popped in my mind as we talk about those differences, and I don't know if there's an answer, but that's just been on my mind since we started. So, you know, if we can't get men to use condoms, we really probably have a hard time getting them to use dental dams.
I have a question actually for people who are here. What education do Clark students get now when they first come to Clark? Is there something standard that students get as an education about these issues? No. Okay.
Nothing standard.
Choices, which we've been part of that.
There's a safe sex student-run organization on campus, and they have office hours. But having worked there, they get maybe a few students to drop by a month, and it's usually just for common purchases. It's nothing to do with counseling, although they are trained for that. And there's programs that go into residence halls, but in terms of standard and protocol, there's nothing in those laws.
One thing the RAs, I think, and I'm not, Shelley does the first-year halls, one of the first-year halls, but I know in the first-year halls, the RAs are really good about bringing in choices, which is good, because I think they're a good target audience. And they also usually get good attendance versus some of the other class models that give a hard time and said, oh, we've been through that already.
Right.
Yeah, and I think you raise a really interesting point about sort of, if you're thinking beyond condoms, how do you introduce other stuff and have it be accepted by people? And I think that's the real challenge. And you have something like dental dams, which, on one sort of basic level, has anyone seen this? It's a great opportunity to pass some of this stuff around.
That's part 2 of my thought, is that they're not great, they're just the only option right now.
Right.
That's what I think.
Here are some of the things that have come up with dental dams. The first is that dental dams are literally used for dental surgery. See, originally, you'd have this like really thick piece of latex that wasn't much fun at all. And then you move from there to these things called lollies. But the problem with lollies is that they were produced in Australia and didn't have a real distribution network here in the United States. So now there is a US-based company that manufactures these.
Glide dams. And they are much thinner than the original. I mean, when I was in college, which wasn't so many years ago, and they were passing around dental dams, they were these horrible thick things.
They're
And
like
that was
this
true.
bigger.
And they're little, right? I mean, come on. You're going to feel something through that? These are better. They're nicer. They're kind of like silky, and you can see through them a little bit, and they stretch really nicely, and they're bigger. So we're seeing advances, but they're still, when Marshall and I give workshops on this stuff, the students say, where can I get those and how much do they cost? So that's a real issue. They're not around.
Choices carries, and the
Choices
general
carries.
store has them right on the counter at the general store here.
That's great. And then, I mean,
Another really inexpensive and also very accessible alternative is saran wrap.
and I've said that I can start a one-woman campaign for this stuff because I like it a lot better. Its effectiveness is very similar to dental dams. It tends to be around the house. People tend to have access to it. Students probably less so because they don't usually have kitchens, especially low-level first year, second year students. But you can really big pieces of it. You can see through it, and it's very thin. It's as thin as that is. So I just think it's interesting that we don't hear as much about this as we could. Suppose it's better to use when you're teaching about this stuff. It's better to use non-microwavable saran wrap than microwavable because the microwavable is a little bit larger pores supposedly. But any saran wrap, no matter what it is, better than nothing at all.
If you've got
if you're worried about exactly.
right, where you're using saran wrap, then the difference in microwavable and non-microwavable isn't that great. Yeah, I mean, I think just to key off this, I think another thing that comes up is female condoms. Do you have female condoms on this campus? But I think one of the things that's interesting about the way in which female condoms work is just because you have a new form of safe sex, it doesn't mean it's going to catch on immediately. Here's the package for this is what it looks on the outside, and this is the inside. You're welcome to take this out. But a female condom has an outer ring and an inner ring. So in order to put it inside a vagina, you would squeeze the inner ring and push up inside. The outer ring stays on the inside. And it can also be used for anal sex. Some people using it for anal sex would take this ring out because it's harder to stick this ring inside the anus. But some people would leave it in. And we keep it in this bag just because it gets a little sticky.
But you can.
Because it has to go all This is not a used female condom.
So are there free condoms on this campus? Are there places you can get condoms for free? Okay, but condoms are basically it. That's all you can get for free. Something else you have to go buy?
No,
Oh, no.
Choices gives out some
Choices
stuff.
gives out stuff?
We ask for a donation, but if they can't afford it, it's yours.
Okay.
Yeah.
And I think that this is really needed during orientation. Maybe we can push to have that because we have a lot of situations with alcohol, with drug use, and no matter how bad we want to push it in the closet, for lack of a better term, it's something that has to be, deal with race, deal with religion. We have to deal with these other issues that are so prevalent behind closed doors and not out in the open. I think this is really needed, and like that has come a long way too. Because I remember seeing it in the '90s with early names, and it was very, very different. It wasn't packaged properly. It wasn't packaged as, it looks user friendly now, but it just was not packaged so that people would be able to go and utilize it.
Yeah. But I think the idea of thinking about, I don't know who here has the power to do this, but I know some schools do have a sex education component of their orientation.
We're on the deep
So
side.
they'll have education about it. And I don't know enough about how Clark
No
works.
pressure.
No pressure.
I don't know enough about how Clark does this, but some schools do. During their orientation, they have a section on sexual assault and a section on racism on campus and diversity and all those things, and they'll have a section, and some of them will have lesbian, gay, bisexual, transgender issues, and some of them will also add in the safe sex component, where the assumption is that we're going to pass on everything, and everyone's going to learn what a dental dam is, and everyone's going to touch a dental dam, and everyone's going to get to squeeze the female condom ring and see how that would feel, so that it's not broken down into, only the gay students, only the lesbians get to see the dental dams. And having that assumption that whenever you're doing education with a group, just keeping in mind that there are always lesbian, gay, bisexual, and transgender students in the room, assuming they're in the room, and dropping it, mentioning it, whatever you're doing, is something that I find makes people feel really safe and bring up questions. I had an amazing experience. I worked in adoption before I did this, and I would give workshops on adoption at national adoption conferences, and was giving a workshop on non-traditional family adoptions, and happened to mention transgender adoptions and said transgender people do adopt. And I left it at that. That was not my focus. I just happened to say the word because I'm committed to just throwing these things out there as I go along. And after the workshop, I had all these people come up to me and say, I never heard about transgender adoptions before. Who's doing transgender adoptions? I had a transgender person call me. I had a transsexual call me, and I didn't know where to refer them. How can we do better with this community? And it's the kind of thing where all it takes is throwing the word out there casually in the middle of a long thing that you're doing. And the people who care about it will then know that you're a safe person and come to you.
And that's a great way for the people who talk about being a person who's out there that people feel comfortable with. I mean, that's a great way, is if you start talking about this stuff and people perceive you as an ally or at least someone that they can trust, then they do come up to you afterward and say, talk to me more about this.
Some people I know, the discussion with some online list I was on, have get different kinds of stickers to put on their offices or near. So there are, some people put up rainbow stickers or safe space stickers to imply that LGBT students can come talk to them. I don't know what the equivalent would be for safe sex.
Well,
you can make your own sign. That's true.
A good start.
That's true. You can make your own sign that says safe sex discussed here. And just have it there. Don't talk about it, it's just there. Or whatever message it is that you want to be communicating, so that when students are in your office, that's even an idea that they would have, that you're a person who's comfortable enough to have that on your bulletin board.
With the female condom, because both ends are open, how does that prevent any
They're not actually both open.
Yeah.
Oh, I didn't take it out the bag.
Yeah.
One ring is covered.
Okay.
Yeah, it's basically like a big condom. Like a big. So this end is all closed in all the way.
Okay.
Yeah. And the inner ring is just to kind of anchor it against the woman's cervix.
And to go back to your point about other types of latex, like a female condom for me is a perfect example of sort of the challenges of something new, like other than condoms. And that I've heard safe-sex educators go up and talk about as this miracle thing. As though, like, for women, for example, using a female condom as other partners could never tell. When you use a female condom, like, he won't even know the difference. He won't know you're using a condom at all. And you go up to her and say, have you ever used a female condom? Do you understand how they work? They're like, oh no, but that's what I heard. Well, it's possible that a partner would not know that you have a female condom.
It's really dark. Because it hangs out of you.
So on the one hand, it's not this miracle thing that you put it in and it's going to disappear and no one will ever know the difference. On the other hand, for some people it works well. For the people who are like, it interrupts the mood. Well, a good thing about a female condom is that you can, put it in up to 8 hours before. For people who are like, I can't come inside a regular condom, like there's not enough sensation. Many men, not all, but some find that it more pleasurable to come inside a female condom.
So other things people want to talk about from that or from other things that we've said, we have all kinds of places we can go with this.
I just have a question.
Yeah.
You mentioned earlier when you were talking about the inclusive latex, you were talking about various types. You said something about a finger or something. I'm not
Finger.
familiar with that.
Okay.
I was just wondering.
I don't see them around much. They may be on their way out. This may be like early 90s, but you can still buy them.
So a finger cut is a variation on a glove. So a latex glove you can use to protect hands when using hands in sex, particularly for penetration with hands. And it's good protection if people have cuts on their hands and are concerned about that.
I'm sorry.
Sure. Okay.
You break out all this stuff during that time, and it's like, it's over. You got gloves, you have the condoms, you have all this, like, extra stuff. Like, you have to do 8 hours, and something else is 2 hours, and,
Right.
you
This is a
build the
finger cut.
momentum for all of this.
It's like a teeny little condom and it rolls up.
If you pass around the finger cut. You mean when you're having sex?
Like,
Or when you're teaching it. When you're having sex, when you're teaching about it.
when you're teaching it, like, certain things, you have gloves, you have the plastic wrap around, this, and you're giving out all this information. How do you make it more of a situation where it's like more comfortable to really handle all of the things at one time? Because I would love to call you on like 911 and say I have a person here asking about this question. It's asking me about something. And how do I handle it? Like to actually sit with someone and actually talk to them about, right?
Well, I think what you do, and again going back to the sort of what we're calling the student-centered model, is you assess where people are at.
This is if you're in a one-on-one situation.
If you're in a one-on-one situation like you described, you assess where people are add before you educate. For instance, if a person comes in and they're concerned about their risk around HIV, and the reason why they're concerned is because they have vaginal or anal sex without a condom, then that's a much higher risk category than not using a glove or a finger cot or a dental dam. You know, based on the brochure, this brochure on the back breaks down some of what's high risk and low risk.
The black brochure.
Yeah, the black brochure. So, and here's some more over here. So you have things at the very top of the, you have things that are very top that are high risk categories. And people who come in talking about high risk experiences, you work on that basic level. People who are having unprotected anal and vaginal sex and are concerned about their HIV risk don't necessarily need an education in gloves and finger cots and dental dams.
Right, if
Because
having unprotected sex, the point is not to get them to put a little thing on their finger. That's not where their highest risk is at.
yeah, I mean, that's not what they're coming in to talk about. But then also recognizing that if a person comes in and describes anal and vaginal sex without a condom, using a condom is not necessarily the only way to get them to reduce their risk. There's sort of other ways to work with them around that issue. And in fact, maybe should we do an example of that process? Yes.
I was trained as an AIDS and HIV peer educator, and I think if you're explaining something to someone or if they come to you with a problem, you need to be comfortable, like within yourself, to talk about that, and that's like really the first step. Because if you're like appalled by their question and you show that, then that's you lost part of it.
And right there. Or if you make an assumption that's wrong.
Right.
If someone comes in and talks about having sex with someone of the opposite sex, and you can't make the assumption that's they only have sex with people of the opposite sex. And if you make that assumption, as straight people, or something that you say implies that, they may never feel comfortable talking about sex with a woman, sex with someone of the same sex. So confusing. So yeah, I think you're right. You have to be comfortable with whatever comes up and not make assumptions right from the beginning.
Yeah, I want to give you an example of how to do risk management with people. Will people find that helpful? Potentially this. So let's just take the risk. We'll just skip the risk management part.
Okay.
Okay. So let's over and over when people come in for HIV test counseling, or when they call HIV and AIDS hotlines, a common question that comes up is, how risky is oral sex? So what's helpful in terms of that is to break down, like, where are people at with oral sex? I mean, a common question, the first thing, if someone says, how risky is oral sex? The question you want to ask back to them is, risky compared to what? What are you framing this in terms of? Risky compared to, not using a glove during sex? Or risky compared to anal or vaginal sex without a condom? So, a risk management thing like this looks at what the pleasurable behavior is for people. So in this case, oral sex would be a pleasurable behavior. And then if people brainstorm what's that?
Really tall. Notable.
It's really what the meaning is. So what are some reasons that people have oral sex?
Yeah.
Yeah.
What's
What's
fun or good
pleasurable
about
about it?
it?
Why would you choose to have oral sex?
Yeah.
Why not? I can't say what I really think.
Tell us what you really
If it
think.
feels good, do it, I guess, to a certain extent. Within
Okay.
some limits, obviously, but
So it feels good.
not a bad thing.
Yeah, it's not a bad
For
thing.
some people, it's the
So
way
I-
they have sex.
Mhm. Yeah, I mean, Dorian and I lived in Rhode Island about 2 years ago, and there was a big debate over the sodomy law. And the sodomy law included oral sex, which for a whole number, I mean, in addition to sort of the homophobia, and then many lesbians and gay men and bisexuals have oral sex as well as heterosexuals. There's a lot of homophobia there. But in terms of some people with physical disabilities, oral sex is the only way that they can have sex. So.
Also, there's some ways in that, but it's unlikely that you'd ever have someone become pregnant that way. So heterosexual couples can lower their possibility of having conception.
Yeah.
Make them all sex.
So for some people, oral sex is a risk reduction technique in and of itself. They don't want to get pregnant. So they choose.
It's interesting, during one of my programs, people asked me if it's possible to get pregnant if she's receiving oral sex.
What do you tell them?
I said, no, it's digestive here. It doesn't go to the other reproductive system.
Yes, that's right.
And some students think they're not sexually active, they're only having sex.
That's a great one.
Bill Clinton. Oral sex, the President of the United States, the leader of the free world, says that oral sex is not sex. And it was really interesting. There was an article in the Boston Globe maybe a month and a half ago. And the front page of the article was teenage boys choosing to be abstinent. And it had the photograph of like these boys that look like teenage boys, right? Baseball cap, like no mistake about them. We're photographing teenagers here. And the lead into the article was, isn't this interesting? Not only are teenage boys abstinent, but it's not that they're not having sex because they're asking people out and the girls want to have sex with them. But this is actually a philosophy of theirs. The boys more and more are taking on sort of abstinences as something that they espouse. Well, you get halfway through the article and it sort of meanders through all these different statistics. Halfway through the article is a little discussion about oral sex. And just the opposite. Not only are these boys having lots of oral sex, they see it as like kissing. In fact, there's one quote in there that's like, oral sex is just one step beyond kissing. And I think it's sort of an interesting way in our culture's mixed messages and the way people understand this. So, I mean, what a great way. Culture says be abstinent. One meaning of oral sex is, hey, it's a lot of fun for not having to worry about losing your virginity.
Do you have something else to say there?
Yes, I'm Joan McGrath and I work in health services, but when I ask students, are they sexually active? They say no. And I said, well, are you having intercourse? Are you having oral sex? Are you having genital-to-genital contact? The answer changes. So, I mean, Bill is not wrong. I mean, most students, most adults think that oral sex is not sex.
Right. And when people say be abstinent, they don't usually say exactly what that, like how far can you go before you're not abstinent anymore? We have a great worksheet about that, with a list of all the different sexual behaviors. And some of them are very clear. Kissing, you can probably, if you're being abstinent, you can probably still kiss someone. But then where does that stop? And it's a great example. So should we move on to the next
let's
one?
move. So what are the risks involved in oral sex? And think broadly, not just HIV risks.
Maybe sexually transmitted infection.
Yeah, sexually
Whether it's
So it's-
hepatitis or
What else?
gonorrhea, syphilis, all the
Lots of
STDs.
STDs.
Et cetera.
Definitely.
Yeah.
It's a
Obviously-
predictivity.
Obviously, HIV, you're at risk for HIV.
Mhm.
We spread it, I mean,
Uh-huh.
at different levels depending on what you do.
Anything else?
Some people
There-
don't like it, don't like the taste, don't like the smell, don't feel embarrassed or ashamed about oral sex.
Some people are afraid there's a risk of choking.
All right.
Okay. So let's talk about risk management. And I'm interested. Let me just answer one question on risk management. Obviously, using condoms or dental dams is one way to reduce the risk. So let's just put that down. We know that already. But what are some other things you were talking about? You sort of said as there's a risk of HIV, but it depends upon what you're doing. What were some of the things you were thinking about along those lines?
Well, I don't know how this really fits with risk management, but I think depending on if you're giving or receiving, it can be a different level of risk.
It's a great point.
Definitely.
And I saw on this that they showed receptive, they talk about receptive versus assertive intercourse, but they don't really do that. And they do it a little bit with oral sex on a man, but not, they don't really do it with oral sex at all, as far as differentiating between giving and receiving.
Right. And
Vaccine.
if you're giving oral sex, so you're the one with the mouth, the other person's genitals, you're the one who's generally in a position of higher risk than the person who's receiving oral sex. So there's a real difference there.
Yeah, and if you're the person receiving oral sex, the risk that you have is basically whatever the risk of what you can catch from their mouth, which in terms of HIV is pretty low. I mean, for the most part, we don't have can't get, you can't get HIV through saliva. There aren't, you're not hearing a whole lot of cases about kissing or whatever. So mouth is pretty safe. Not necessarily for some STDs, such as herpes. I mean, herpes can be transmitted from sores on people's mouths to genitals, but it's certainly a lot safer in terms of HIV.
What are other ways you could reduce your risk if you're having oral sex?
But the only thing I want to say about that is that even though there's a difference between giving and receiving, one person's always at higher risk, so it would still involve, I don't know if there are any risk management techniques beyond the dental thing with any kind of barrier. So that's a question I would have.
Right. I mean, those would be the only barrier methods, I guess, for oral sex.
Yeah.
But that's still part of each person making their own decision. How much risk am I at right now? Because am I going to be the one giving or the one receiving? And two partners might make different decisions. When I go down on you, I'm going to do this, and when you go down on me, we're going to do something different because of how you personally feel about risk, or because what we know about, sores or some exposure that you have, or whatever. Each person might make a different decision just based on which end that they're on.
So another way is on this brochure, actually, and it has to do with performing oral sex on the man as to whether or not he ejaculates. In that, if a person is performing oral sex on a man and considered by HIV risk, not having him ejaculate in your mouth puts you at much lower risk than if you did ejaculate.
So again, not zero risk, because there's pre-cum and because there are other risks involved. But it's a way to reduce your risk. And for some people, that's the goal. If you're just not going to put on a condom to give a man oral sex, because either the man doesn't want to or the person who's giving the oral sex doesn't want a condom in their mouth, then that can be a big, a really simple, straightforward way to reduce risk.
How about other ways to reduce risk of STDs? Yeah.
The number of partners?
Absolutely. Definitely. A great way to reduce your risk around oral sex is both number of partners and knowing who your partner is, right? I mean, if your partner doesn't have an STD or doesn't have HIV, you're not going to get it from them. So some people, part of a relationship is building up trust with each other, and they may choose to go get HIV tested, or they might, as part of the sort of discussing, getting to know each other, they talk about what their risks are, whether or not they've ever had an STD. Do you want to talk more about the sort of communication piece of that?
Yeah, well, this is another couple things about that. This is another place where people might make different decisions in different situations. So they might think to themselves, how well do I know this person who I'm going to be having oral sex with? And if I don't know them at all, I may choose in this situation to use a condom or a dental dam, or to make a different decision about having oral sex. And if I know them really well and trust them, and this is kind of intuitive, like, people who are in very long-term relationships often stop using condoms and dental dams for this reason. I know this person really well, I trust them, I have more information to make my decision on. And a lot of people, I have a rule about asking partners I'm with whether they know if they have any STDs or if they've been exposed to them or if they're HIV positive, if they've been tested. So I kind of roll my eyes and I ask the question, and I hate doing it every single time. But it's something I do because I've kind of made the commitment to doing it. And nearly every time the other person says to me, they're kind of relieved. And they say, oh gosh, I know we're supposed to talk about that, but I always remember bringing it up. And then we have a discussion, and then we both have more information, and we kind of go on and make decisions from there. A lot of people really think that if the person were HIV positive, or if the person had an STD, they would tell me. So I don't need to ask, because I like this person, they're a nice person, I'm sure they would tell me if they had something. And what the statistics show are that people who are HIV positive and people who have STDs often don't tell, not because they're not nice, trustworthy people, but they don't go out of their way, they don't initiate telling unless they're asked. And they say, I'm being honest. I'm not misleading anybody. If somebody asks me, I will tell them. And if they don't ask, that must mean they don't care. It's not important to them. So that's a really interesting fact to know, that there are a high percentage of people out there who won't go out of their way to tell you unless you ask. And that's an important, very minor way of protecting yourself beyond condoms and dental dams, to be willing to ask the question. And maybe it's harder. Maybe it's easier to just put on the condom and not ask the question.
So kind of asking is a risk reduction.
But the other thing is how do you know how truthful it is?
There's that issue too. And you
Right.
never know
Until you
100%.
know somebody really
Yeah.
well.
Right. So
And
there's that issue.
that's the thing about risk management, what's sort of interesting about it, is that nothing in the risk management category will get you back to sort of the safety that some people feel around abstinence. Or especially that some educators feel around abstinence. We're like, we really want to make sure they're 100% safe to be abstinent. But the reality with the reason why risk management is useful tools is because so many people aren't abstinent, so many people don't use condoms. I mean, you look at studies, people aren't using condoms indefinitely for oral sex. So you're like, okay, how can you work with that? But when you're working with any of these categories, you're absolutely right. You don't want to give anyone the impression that, oh, all you have to do is ask the person, and then, if they say they don't have an STD or HIV, then you're completely safe. I mean, you're right. They may not be telling the truth, or they might not know. They might not think that they're.
Or they might have misinformation, which they think they're telling you the truth, but we just being unclear about what the symptoms are, what they are,
Definitely.
how it can be spread.
Definitely. So if you're gonna ask, you then also have to add in when you're in your decision-making process. Well, how much do I trust this person? How well informed do I know who I think this person is? But by asking, at least you have more information to go on. And most people, from what I think I've read about it, correct me if I'm wrong, most people try to be honest if they're asked. And of course there will be people who lie, but at least you have a better chance of getting some honest information than if you don't ask at all.
So any other ideas in sort of the risk management category for oral sex?
I think the other issue too, the risk management, is what is the emotional attachment that someone has to the activity, not just to the person, but to the activity, whether or not what their views are connected, or it could be just a total disconnection to whatever the activity is, versus being much more connected, may allow them to be more outgoing or more forthright with what it is that they expect. So I think that's one of the concerns that you have, is how emotionally attached are you to the activity, not just how informed you are. And those type of things may
Definitely. And that kind of falls into the meaning. Is that what you're going to say?
Mm-hmm.
Falls into the meaning of what does this mean to you? And there's some gay men who won't have anal sex because they say that's not that important to me and it's higher risk, and I'd rather have oral sex anyway. And so that's their way of dealing with risk reduction. And some people do that around oral sex, and people, the meaning is really important. Some people will give things up or make different decisions based on what it means to them. And you can't go out and tell everyone in the room when you're doing sex education that you all need to make the same decision, because obviously people will make different decisions based on their personal tendencies. I have one other one to put up here, and that's being able to see. If you're having sex in the dark, you have a lot less information than if you have sex with the lights on or in daylight. And I'm not saying that everyone should always have sex with lights on. Some people are not going to do that, but that's another way to gather information. Can I see sores on this person's genitals? What's going on here? How clean does this look?
What's that?
You gotta put on those big miner's hats for the lights.
Safe sex tool, add it to the bag.
Going down with hot swabs, Queensy dishes.
I hadn't thought about it until you mentioned the ejaculation one, but I'm supposing if you focus more on the clitoral area of the woman than the vagina, you'd be apt to come into contact with less fluid. I'm assuming that, so maybe that would be one way to lower some risk. I know it's not 100%, but
Yeah, I mean,
it seems that way.
Definitely. I mean, in terms of, there aren't, unfortunately, it's hard to do a study on something like this, because it's hard to get like the control group and the group that's going to do it. But at least in theory, if you're concerned about, how do you get HIV? Through bodily fluids. How do you reduce your risk of HIV? You reduce your contact with bodily fluids. Well, if you're performing oral sex on a woman, there's a way you can perform oral sex where you really get your face in there, and for some people it's a lot of fun, right? You're totally into it. And then others are more like that, okay, my tongue is a really useful tool for pleasuring a woman, but I'm not, I'm going to be sort of limit my exposure to fluids.
And again, realizing that a woman's vaginal fluids are less risk. So all these different things that add up to, you can take different combinations of these. You can say, I'm in the dark, but I know this person really well. Or we were HIV tested, so I have this piece of information. Or at least it's light, I don't know this person, but I can make this decision. So you can kind of add these things together.
I just want to throw this in here, and I know this is also something that people just don't talk about. Some people could be uncomfortable with, but you also have to be careful about women who are menstruating with oral sex, because of course with blood there'd be a lot higher risk. And some people don't have oral sex at all, but some do. So you want to be really careful about that.
Yeah, and that's a risk
During
reduction.
menstruation.
Right.
In terms of, not.
That's a great point too.
Yeah.
And that's another time people might choose to use a glove or a finger cup too, because blood is a higher risk fluid than vaginal secretions. All right. So this is basically, you're not necessarily, if you're sitting there with a student, going to write down these categories. You might write down these categories if you think it's going to be helpful to clarify, but just in terms of seeing how these different things interplay and how you might help students think through ways to reduce the risk from wherever they're at. For some students, that might mean going to 100% condom use. And for some students, that might mean making other commitments or other rules for themselves and being able to just make better decisions when they're in the heat of the moment.
Thoughts on this, or anything that we've covered so far?
I'm curious. I know a couple of years ago the abstinence push was significant, but some people would throw that out right away because they just wouldn't consider it. Is this something that you find people find more palatable in terms of a reality for them? Is it, could they see themselves managing their risk more than they could be abstinent? Is that more accepting or acceptable for them? Do you find it?
I lost you on the last part.
Okay, I'm just curious, knowing that some people toss out the abstinence argument entirely and say, forget that, I'm not going to do that. Do you find this is a medium point for them to hit and they can actually deal with the issue of risk management? Or do you still find people resistant to changing their behaviors in any way?
I've been hearing in high schools that abstinence is catching on more, that there's almost a move, more students are deciding to be abstinent, but that may still be a small percentage overall.
Well, and I think it's becoming trendier to say that you're abstinent.
And then go out and do everything but.
I mean, as we talked earlier about the example about oral sex, but also I think the secondary virginity thing. Yeah, people heard that.
Oh, you don't do it for one time, and then every time for the first time.
Yeah, well, basically, if you have an abstinence-only curriculum, what do if you have students in your class who, speaking of high school classes, if you have students in your class who've already had sex? And what the solution that people have with that is to be like, oh, you can be, you can become a virgin again.
So after this moment, you're all virgins, and as long as you never have sex again, you'll all stay virgins, and we'll re-give you that credibility.
But, what's that?
It's a joke. Sorry.
But I think risk management is a really useful tool that takes people where they're at. If people come in and they say, I want to know about abstinence, I want to be abstinent, I want tools for working with that, that's great. Like, that's risk management in a way as well. But if most people sort of aren't there, and most people aren't even there necessarily in terms of using a condom. So you're like, okay, what else can we work with around this?
What we find is that students are they're pretty knowledgeable about condom use and about the fact that dental dams exist, which is what you said, how do we get the knowledge to turn into behavior? That really seems to be the issue because there has been some pretty good, mixed sex education in high schools and in colleges. And then you get students who have the information but they're deciding whether or not to use it. And if all they have is an acyclovir and a condom, they have less ability to make good decisions than if they are more informed about thinking these things through, kind of in a risk management way.
So let's talk a little bit about behavior change.
We have
We have about
2 minutes.
Okay, and then we have dinner, right? We got to be able to eat. Reception. Good food, so stay around. But I know there's some health educators in the room. What about issues like smoking and stuff like that? How do you get people to stop smoking? It's hard, isn't it? It's really hard. And it's trendy too. And you have the there's some smokers in the room?
Yes.
Yes. I have an answer when you're I smoked frequently I didn't smoke at all, then I smoked a little bit, then I smoked a lot when I got here. And now I'm down to a couple of cigarettes a week. I haven't seen you for a while now. Oh, no. But for me, there were a couple experiences where people had some lung cancer scares, and I read an article by someone who had emphysema and talked about smoking. So for me, but there was a woman on campus actually who had a lump in her spot on her lung, and she had tested, she's fine, but it just made me go, ooh, I don't want to be her in 20 years and have that scare. So some of it was flushing out in a real person the risks you hear about. Reading the side of a cigarette pack doesn't really do it.
So for you, it sounds like part of what happened is the awareness of these risks, the sort of first-hand experience of what it was like.
Well, I think the awareness was there. I think the connection to me was different. This person I knew got one of those things on the side of the cigarette pack. It does happen to real live people, so it's interesting.
It's the same thing too. I mean, I just watched my father get real sick this year, and I was in the hospital constantly, and every single person that came in contact with me, this is about smoking, but really smoking, smoking. That's every single person I walked up to talked to me about that, and I'm just worried. I worry about now other people who I didn't smoke because I don't. But I think you always know it's there, even these risks or any other risks, unless it affects affects somebody close to you, sometimes you have that invincibility feeling. And I think a lot, especially developmentally, students high school and college age still have a very strong feeling that nothing bad's going to happen to me. So getting beyond that, bringing it closer to home is very challenging.
And it's also challenging to do without just using scare tactics. Without just saying, this is so awful and scary and horrible. You know, you never, ever, ever want to do that. And when students look around them and they say, but I don't know anybody, my whole family, my whole circle of friends, and you know, my parents' families and friends, if I don't know anybody, then how can it be so dangerous? And it's hard to figure out how to get across the message that this is important and risky, and also that this isn't necessarily the only risk out there. We have lots of risks in our lives, and you know, this is one, and it's an important one to think about. It's a real one.
I think the difference between smoking and the issues we're talking about here is that I think anecdotally you hear more about people whose relatives die of lung cancer and emphysema. Really, you hear someone saying, "Then you know, my sister got herpes," and they talk about it, and you go, "Oh, that's." Those are typically hidden stories. So I think for me as a smoker, still sort of, I was hearing more of that than I would hear about this stuff.
Plus, it's
See you
people
later.
are impulsive about sex because they're in the moment and nothing's available. They don't want to stop. So it's a little bit more of an impulsive thing.
Yeah.
But it's interesting, even the impulsive can fall under working with risk management. And part of the work that I do is to counsel clients one-on-one. And it's a whole curriculum to work with people individually, which is great. I mean, behavior change is a long-term process. It takes a lot of work. So it's great for all of you in a position to work with people one-on-one. That's wonderful to be able to do that. But you know, it's very interesting. And I'm blanking on what you just said that I was going to.
Oh, just about impulsive.
Oh, right. Having condoms nearby. So many people, you know, the problem is that they're in the moment, and the condoms are out of reach. Well, for some people, it's a risk reduction technique just to have condoms available for them.
Keep them on the bedpost. You hear about people doing that.
Yeah.
And I remember, I mean, being in college, some of maybe the most important thing that happened in my dorm was that there were condoms taped to the resident counselor's doors. And I don't know if you do that here. But I mean, I vividly remember people in my dorm, you know, we'd all have our doors open, and there'd be somebody with the door closed, and they'd come out in the bathroom, and they'd go, for condoms? For their condoms? And everybody would know what was going on. They'd kind of walk down the door, and rush on that door, and they'd walk down to the next counselor. And there'd be periods in the year, occasionally, when like none of the counselors happened, they all happened to run out. And they'd be walking up and down the hall looking for condoms, and they wouldn't find them. Or maybe somebody would say, oh, you know, if you go down the floor, and they'd run down and get one and come back. Or they would give up, and they'd go back to the room. And I don't know what happened then. Maybe they decided not to do whatever they were going to do with the condom, or maybe they did. And there's a perfect situation of the impulse and the importance of having them within reach. And you know the story about that too.
Oh yeah, well, freshman year I lived in a dorm where cinder block walls, so you could hear everything. And at 3 o'clock in the morning, I got a knock on my door. I was sound asleep and woken up. And there was a guy who was taller than I was. And there aren't many people who are taller than I am, so I'm like, whoa, 3 o'clock in the morning. And yeah, he's wearing briefs and nothing else. And he says, oh, do you have a condom? Your next door neighbor, he thought that you might have one. So I like rooted around and like gave him one, and then he had the condom. But it's interesting, I was like, how did she know that I probably had condoms? She could probably hear everything through the wall.
All right.
So, we should wrap up. Yeah, we're coming to the time, and it sounds like we can hang out here as long as people want to, but I know other people want to go home. So, we'll do a couple things to wrap up. First of all, what's the take-home message from all this? Well, there are many, and we can talk, you know, about some of them are individually. But for me, what the take-home message is that there are many paths to people living healthy lives. That HIV risk reduction is about healthy lives. And risk management is about healthy lives, whether you're talking about smoking or, you know, wearing a seatbelt while driving and all that stuff. And we need to think beyond the box of either be absent or use condoms, because a lot of people just aren't there. And to work with people around these kind of issues.
Well, we need to do that. We do need to say you can be abstinent, you can use condoms. And we need
Right.
to do all the good education that you guys are already doing. The next step.
Yeah, exactly. And the next step is to work with people to think, you know, how does this apply to their lives? What are the risks that they take? And how can you help them reduce that risk? So,
That's good stuff.
okay, lots of goodies for you. This is a resource sheet. The organization at the top, the American College Health Association, actually made these pamphlets that you have. So it's great to see that you're already tapping into that resource.
This is an article that Marshall wrote about safe sex.
So this article talks a little bit more about understanding risks and how that works. You'll find that I'm a little bit like diehard on the. Got distracted.
Do not distract the man.
You'll find in this article, Eroticism After the Moment, I'm a little bit diehard on like just use a condom.
And he's younger than.
So, and I'm thinking sort of beyond that, I'm realizing a lot of people are.
You want to talk about this one, Ellen Goodman? Molly
Yeah.
Campbell?
This is a really interesting article about risk-taking in general, and it's dated. It's from 1985. Well, what was going on in 1985 with HIV risk? You had Ryan White and people concerned about kids in high schools and whether or not they could get infected through casual contact. So I think it's a really interesting snapshot into history in terms of how people understand risks in their lives, and realizing that the risk of HIV infection is just.
We should get that stuff going around while we have
Oh, good.
I
Okay.
have so many papers for you.
These are evaluation forms. They're blank pieces of paper. And what we're interested in is what did you like about the workshop, and what would you change about the workshop?
And that's really helpful because it's improving workshops in the future.
And one final piece for you. This is from Gay Men's Health Crisis in New York. And they do work around substance use education. And I think it's a really good discussion of some of the issues that gay, lesbian, and bisexual people face, as well as looking beyond just sort of logistics of alcohol and drug use and safe sex to some of the deeper things that are going on in people's lives. And I think this timeline of a person's life, even though it's difficult to read, is really revealing and conceptual.
We also have sheets where you can give us your name and address and email address if you're interested in hearing about other workshops that we are doing in this area or at Clark. So if you want to be in touch, this is already our second trip, and we hope there'll be many more. That's it, right?
That's it.
All right. Well, thank you very much.